Good morning, everybody, and thank you, Quresh. Uh, I'll be dealing with keratoconus and the current management options that we have. When you talk about corneal ectasia, it not only includes keratoconus, but also the post-LASIK ectasia, the pellucid marginal corneal degeneration, and keratoglobus, what you see in your clinical practice. This paper summarizes the global consensus on keratoconus and ectatic disease. So basically what they found was keratoconus is, basically it has not only the steepening of the cornea that you see on your Placido topography, but also it has an abnormal posterior elevation and abnormal distribution of the corneal thickness. That means the thinnest point is not in the center. And the corneal thinning, what they concluded was non-inflammatory in nature. Keratoconus and pellucid are practically a different presentation of the same disease, whereas keratoglobus can be considered as a separate entity. Tomography is supposed to be the best diagnostic test, not only for initial diagnosis, but also for follow-up and to determine progression. The pathophysiology is multifactorial, and there are several risk factors, out of which I think eye rubbing and ocular allergy are considered to be the predominant ones. So when you look at a tomography, you look at not only the axial map, you look at the thickness map, and you see that in this map, the thinnest point is not exactly in the apex. It's slightly below the apex. And if you look at the posterior elevation, the two of them, they kind of correlate with each other, which is very important when you make a diagnosis. When you talk about the management, I think we have two things that we need to look at. One is we have to visually rehabilitate, because a patient with keratoconus obviously has a decrease in the quality of vision, and that's one of the primary reasons why he's at your doorstep. And the second thing you have to look at is, you know that it's a progressive disease, so what can you do to stop the progression of the disease? In terms of the halting of progression, we need to identify if there are risk factors present, like if the patient has eye rubbing and ocular allergy, we try to treat the ocular allergy. At Quresh some time back mentioned about in the aspect of treatment of dry eye, you treat with mast cell stabilizers, antihistamines, sometimes in severe cases use some anti-inflammatory medications and lubricants. You can ask the patient to avoid eye rubbing, and this other thing that we can do is we can strengthen the cornea by doing cross-linking. And in future, people are trying to use stromal stem cells to try and increase the population of keratocytes within the corneal stroma, and thereby increase the structure of the cornea. Cross-linking has been present almost for 2 decades now. It's basically application of riboflavin on the cornea, which infuses into the cornea, and then you expose the eye to UVA light that results in cross-linking of the collagen fibers. And this is indicated basically for progressive keratoconus. You need a minimum corneal thickness of about 350 microns, and there should not be any other coexisting abnormal pathology in the cornea. Now, when you do cross-linking, we don't have an exact way of measuring the effect of cross-linking, but indirectly we do see the haze that develops at about 200, 250 microns into the cornea. And you also see some crisscross lines in the stroma, which persists in the early phase, but over a period of 6 months to 1 year, these clinical signs can disappear. When you look at serial topographies, you can see some amount of flattening of the cornea. So it doesn't happen in a uniform manner in all your patients, but the objective is to try and stop the progression. And so we look at the refraction, the vision, and we look at topographic parameters. So you see the steep K reduces, in this case, from 49, it has gone on to 47, and the refraction also shows a change. There are various solutions which are available. Originally, we had the solution that contained dextran, but that results in thinning of the cornea when you apply it. So now we have non-dextran solutions. We have solutions in saline which are used for epi-on procedures as well. There are some procedures that have been developed for combining with procedures like doing LASIK. You have now, besides the classical restraint protocols, you have the accelerated protocols, out of which the protocol that we use, 9 milliwatts for 10 minutes, seems to be the one that's very close to the classical restraint protocol. You can try to improve the penetration of riboflavin into the cornea by using iontophoresis or trying to make a stromal pocket using the femtosecond laser. You know that oxygen is required for the chemical reaction that takes place. So if you use accelerated protocols, the depletion of oxygen from the surrounding atmosphere around the cornea is pretty fast. So they have recommended using pulse exposure, or even increasing the oxygen in the surrounding environment to help the procedure be successful when you're using it for a shorter duration. Variable energy controls, and you have the recent trials of topography-guided exposure of the energy levels across the cornea, so you can have a much more targeted delivery. When you come to visual rehabilitation, contact lenses are still the mainstay for managing these cases, and we use a wide variety of lenses ranging from soft toric in the early stages to using RGP or the rose-scale lenses in most of them, but in advanced cases you may have to fall back on the mini-scleral or the Boston scleral lens. What about topography-guided laser procedure? This is only for a very small subset of patients who have very early keratoconus or keratoconus suspect, adequate pachymetry of at least 450 microns or more. And remember, this is not a refractive procedure. We do a topography-guided procedure to try and regularize the cornea. So the refractive outcome is not the end result. And if you're going to make the cornea thinner by doing a procedure where you remove some tissue from the cornea, you need to combine it with cross-linking. And you should be able to get a reliable and reproducible map to be able to plan a procedure. Giving an example now, this young lady, she came in for a laser refractive surgery. When we did the topography, we found that the topography was abnormal. Pachymetry was 488 microns. She had a best corrected vision of 6.9, so we did discuss the option. So the treatment planning, if you look at the ablation profile, you will see that it's a peripheral hyperopic ablation which steepens the flat part of the cornea, and myopic ablation over the steep area which tends to flatten it. So you're kind of trying to make the cornea more regular. This was the outcome after the treatment. You can see the ablation was only about 40 microns, but her vision improved to 6.6 with just a residual cylinder of 0.75. She was very happy with the quality of outcome. All the topography still shows a little bit of steepening over here. But when you look at the high order aberration, this is what was pre-operatively. You can see the amount of coma was quite significant, and after we did the topography-guided ablation, there was a significant reduction in the coma, and which helped improve her quality of vision. So this is, there are several studies looking at this, and they've looked at that in this small subset of patients, if you do a topography-guided laser ablation combined with cross-linking, you can have pretty good favorable results. Intracorneal ring segments are again another option where you can try using these rings made of PMMA to flatten the cornea. You need a minimal thickness of 400 microns at the site of implantation. And with the Intacs that we have been using, we have found that the results that you get are favorable if you choose corneas where the steep K is less than 60 diopters. A wide variety of rings are available besides the Intacs. You have asymmetric rings, the Kera rings or the Ferrara rings. You have even the Mayo ring, which is a circular ring. And they're quite popular in South America, where I visited recently, and I found that they use this quite frequently in the management of their keratoconus cases. So the implantation is pretty simple. You can use the femtosecond laser to create the channels, and the newer software in most of the laser machines will allow you to create these channels depending on the type of ring that you are implanting. So you can even choose a specific ring of a specific size, and the channel would be made according to the width and dimensions of that ring that you are using. So clinical appearance, it can be done under topical anesthesia. That's what the patient looks. And the best part is it's reversible. That means in case you don't have a desirable outcome, you can always go back and remove the ring. Now, I'll give you an example. Like this is a patient with keratoconus. You can see the uncorrected visual acuity after a single ring implantation. It improved to 6.18, and the best corrected vision also improved to 6.6. And then you can go and, if the keratoconus is progressive, you can do a subsequently cross-linking procedure in that. There have been reports of phakic IOL implantation in, again, a small subset of patients with keratoconus where the cone is fairly central in location, so the patients still have a best spectacle corrected visual acuity of 612 or better. The astigmatism should be less than 6 diopters. The keratoconus should be stable. So both the VeriSize, which is the iris-supported lens, and the toric ICL have been reported to be successful. Just to give you an example, this is one of the keratoconus patients. You can see that he has high myopia, but the astigmatism only 2 diopters, and his vision improved to about 6.9. We went ahead, did a toric ICL implantation, and he had unaided vision of 6.6. And you can see post-operatively, the astigmatism is almost 0, does has a little bit of +1 power. So this is again, in a small subset of patients, this can be considered. When you have very advanced keratoconus or corneal scar in the visual axis post-eye drops, you have to think about, and the patient is not willing to try out the scleral lenses, then you have to try out doing surgical, either a lamellar or a penetrating keratoplasty. Lamellar keratoplasty has become again popular over the past 2 decades, and the big bubble technique is quite useful, and it gives predictable and results which are quite comparable to what we have with a data set with penetrating keratoplasty. Now, this is a patient with advanced keratoconus where deep anterior lamellar keratoplasty has been done. The advantage is that you preserve the endothelium, so the long-term survival of the graft is better and the risk of endothelial rejection is minimal. If you have access to a femtosecond laser, you can do femtosecond laser-assisted DALK where the edges are, instead of being vertical, you can make them shaped edges, and that allows reduces the incidence of, the amount of astigmatism. That's the cross-section, and you can see that's how the topography looks post-operatively. Peripheral thinning like this, advanced pellucid marginal degeneration, can also be managed by surgical procedures like doing a DALK, large diameter. And you can see that's the pre-op astigmatism, which was about almost 17 diopters. That's the post-op topography that looks really nice. Keratoglobus, if you have extreme thinning, you can think about doing epikeratoplasty procedure as well, which itself can suffice to make the cornea, the shape better and improve vision, or it can tectonically make the cornea thicker so that you can go and do a subsequent penetrating keratoplasty. Now, this is a patient with extreme keratoglobus where a DALK was done and he had good outcome. Sometimes we combine, in this case, we did a central dissect, and on top of that, we did like a large epikeratoplasty procedure, and we were able to achieve good visual outcome in this case. We have what we have been trying out over the past 2-3 years is a stromal augmentation technique where we take a 100-micron lenticule, stromal lenticule, we soak it in riboflavin, cross-link it, and this lenticule can be inserted into the corneal stroma at about 200 microns depth. This pocket is made with the femtosecond laser. So basically, we are trying to put in stromal tissue into the cornea, stroma, in an attempt to try and increase the corneal volume and see what the impact is, whether it can slow down the keratoconus progression or whether it can improve the vision. Now, that's how it looks post-op, early post-op, late post-op. You can't even make out the edges. That's the OCT image, and if you see, that's the pre and OCT and the post-OCT in terms of thickness. From 467, it's improved to 566. That's the pre-op topography, and you can see post-operatively, the cornea has become much more regular. The uncorrected visual acuity improved to 636 and a best vision of 6.9. That's the high-order aberration of the same case. You can see there is a significant reduction in coma following the lenticule implantation. So basically, if you have a corneal ectasia, what you need to do is go into the clinical history, look at the best corrected vision, do a tomography. This helps you determine the severity, classify the kind of ectasia the patient has, and then when you have the vision, you go and see whether the patient vision with the glasses is better than 612 or not. If not, can you give a contact lens trial, and whether the vision can be improved with a contact lens trial. So don't just jump to doing cross-linking just the moment you diagnose keratoconus here. You have to you have to pay attention to this part and try and improve the vision. Let's say if the vision can be improved with the glasses or with the contact lenses, then you look at whether there is progression or not. And if there is no progression, you can observe. But if the pediatric case, you have to consider cross-linking, or if the patient is not willing for follow-up. If the progression is there, then you either do cross-linking alone or combine it with other procedures. But in case you're not able to improve the vision beyond 612 or better, and the patient is not happy, no point doing cross-linking or any of the procedures, then you can consider doing other procedures to improve the vision. And if still that's not possible, I think you have to think about doing corneal replacement surgery. So basically, successful management depends on early diagnosis. You have to plan and customize the treatment. Counsel your patients. They have to have realistic expectations. And most important, I think you have to avoid complications. Thank you. Thank you for your patience here.